Good evening. I'm Selwyn Collins of CWS Conversations with Selwyn. My guest, my good friend, I begged her not to make me laugh. And here I am trying to be serious, and she's staring right at me and cracking me up. Anyway, those of you who are joining us for the first time, thank you for joining us. CWS is about having conversations with people about their journeys and how they're using their gifts and talents to help others. So I'm always looking for someone to share their stories because I believe that each of us has a story to tell. And I think that when we share our experiences, when we share how we achieve our successes, how we overcame our challenges, I think that evokes the essence of our humanity and best connects us as humans. And what it does, it helps us to understand that we are not alone in our struggle. And so I often say to some of my guests, imagine a young person somewhere in the world listening to you, marveling at your successes, but at the same time, hearing you talk about some of the challenges you might overcome and recognizing something similar. Now, imagine that same person one day in the future becoming someone who discovered a very important vaccine that stops, that helps millions of people, save millions of lives, someone who stops a genocide, someone becoming a head of state. We have no idea. And I think the true essence of who we are is the ability to give without expectations, to give beyond ourselves. And so I am always encouraging people, when you have an idea, pursue it, believe in it, be passionate about it, commit to it, and pursue it. I really do believe this, and some may have different views about this, but I think that when an idea is given to us, it is not for us to become the idea. I think we are just, if I may use this metaphor, we are like soils onto a seed. And our responsibility, our obligation is to nurture, is to give life to that idea, to make it manifest. And sometimes our role in an idea is really just to lay the foundation. Somebody may take it from there and take it further. And so we have to be able to adopt some level of selflessness and recognize the importance of being given an opportunity to receive an idea and follow through with it. And while I am using this metaphor of being a soil, let me use another one similar called transplant. If you are in an environment where it is not conducive, and when I say that, I mean the people around you, one of the most difficult things for those who are close to you to do is to let go of their perception of who you were when they knew you many years ago. One of the most difficult things for us to do as human beings is to find a way to acknowledge and accept the new you. And so we make it difficult for each other to just transform and be someone else or become who we are really supposed to be. And when you find yourself in an environment that is not conducive for your growth or not conducive for incubating that seed, transplant, move, leave, find another, as a good farmer will know that if the soil is not good for its seeds, it transplant it. Anyway, I just want to use that to underscore the point that when you have an idea, it's important that you commit to it and you see it through. So I am going to take a break, and I'm going to take a break, and when I return, I will reintroduce to some of you and introduce to those of you who are joining us for the first time, my friend Dr. Sharon Griffith. We are back. And those of you who are joining us for the first time, I'm Selwyn Collins, your host of CWS Conversations with Selwyn. The lovely lady next to me is Dr. Sharon Griffith. Sharon, good evening.
Good evening, Selwyn, and thank you for having me back.
You are quite welcome. I want to get right into it, Sharon. I'm just going to read a bit of your bio for those who are visiting this show for the first time. Dr. Sharon Griffith, MD, FACOG, MD, Columbia University College of Physicians and Surgeons, New York, New York, 1990 to 1994. BA in Biology, cum laude, Brooklyn College, CUNY, New York, 1985 to 1990. Licensure and certification, Diplomate of the American Board of Obstetrics and Gynecology, 2002 to present. Medical License, State of New York, 1998 to present. Postdoctoral training, intern and resident in obstetrics and gynecology, 94 to 98. St. Luke's Roosevelt Hospital Center, New York, New York. Academic appointments, assistant clinical professor of obstetrics and gynecology, 1998 to 2009, Columbia University College of Physicians and Surgeons, New York, New York. Hospital appointments, assistant attending obstetrician and gynecologist, 2008 to 2009. Harlem Hospital Health and Hospital Corporation, New York, New York. Assistant attending obstetrician and gynecologist, 1998 to 2008. New York Presbyterian Hospital, Columbia University Medical Center, New York, New York. Sharon, you know, I'm so grateful that you took the time to come back because there were many who learned a lot the last time. You were so informative and so very insightful. And so this is indeed an honor that you've decided to come back. So welcome again.
Thank you.
How may I address you this evening?
You may call me Sharon.
Sharon. Okay, wonderful. As a physician and surgeon, what aspect of your job gives you the most or the greatest satisfaction?
I guess I would have to say that I get satisfaction from different aspects of my job. Um, there is the satisfaction of being able to do a job well done. For example, in case of a cesarean section, a timely cesarean section, for example, for a fetus who might be in some amount of distress or jeopardy, and being able to um, deliver care that allows for a successful outcome. So that's challenging and that's satisfying in order to be able to do that and know when to do it, and I think do it well. But I also get satisfaction in non-clinical ways as well. Being able to impact on someone's life, inform someone, give them information that they may not otherwise have had. It's amazing some things that some people either don't know or are afraid to find out about, or even are afraid to ask. And some things are simple, some things aren't necessarily or don't necessarily require a great amount of medical training, or some things just need common sense answers. So in those ways, it's satisfying because I'm in a position where I can answer questions that are asked most times. And so as I said, it depends on which aspect. I can get pleasure from just being able to answer simple questions, problem solving, investigating, as well as the actual work that I do with my hands.
Mm-hmm. If at any point during your career you had thoughts of another career path, what would that might have been?
That's a question I keep asking myself. I don't know, really. I still haven't been able to come up with the best answer. I'd like to imagine that it could be something creative, and by that, I don't know what that means even. I don't know, it feels that I've been sort of programmed to do what I do from a very early time. So I have sat down, even as recently, contemplating what it would be like to think of another career path or what else I could be doing. Maybe nothing so drastically different from what I do now, but maybe something more in policy, something where I feel that I can make maybe more of a broader impact than just in the clinical sense with the patients that I see on a daily basis.
Has your youthful appearance been an obstacle earning trust from your older patients, your much older
You
patients?
flatter me.
I'm not flattering you. I'm asking you this question because someone asked me to ask you this.
Really?
Yeah.
Okay. Maybe not so much now as perhaps a few years ago. Um, I've heard the occasional comment, that I was too young or I couldn't be the doctor, but I have to say, unfortunately, not as much as before. So, um, not really. Older patients, usually women, because I don't care for males. Um, I don't care for male patients. Uh, they tend to be, I think, more trusting of female providers, it seems, in general, especially the older patients of the demographic that I tend to come into contact with. They tend to be more willing or more desirous of a female practitioner, so I don't think the age matters as much.
Hmm. What do you see as a negative growing trend in your field that concerns you these days?
A growing trend? The things that concern me aren't necessarily a trend, they seem to be just a fact.
Hmm.
Um, you know, I'm concerned about obesity,
Hmm.
especially in women, especially in women of color, but in all women. Um, and teenage pregnancy. Those are my two biggest. Those are the things that really concern me the most in my encounters with women on a day-to-day basis. The things that concern me a lot are is the high incidence of teenage pregnancy
Hmm.
and the great incidence of obesity that now is present in our population.
As an obstetrician gynecologist, how would you say the problem of obesity would affect, let's say, fertility?
Well, obesity can have a great impact on fertility because we know that weight plays a very important role with regard to ovulation. Ovulation meaning the production of eggs from the ovary.
Hmm.
And while it doesn't necessarily affect every obese woman, there are more and more women who are obese who have difficulty with ovulation simply because of their weight.
Hmm.
Um, Not only does their weight impact ovulation, it also can predispose them to diabetes or insulin resistance, as we also call it, which is a propensity towards diabetes where insulin isn't able to do the job as well. And that interacts in so many ways with the ability of a woman to become pregnant and manipulates her hormonal status and her fertility status in a very negative way. So yes, obesity oftentimes is linked or associated with conditions such as polycystic ovarian syndrome, which is a condition where weight does play a factor in about uh, 80 or 85% of cases. The persons who are affected by this condition are obese and have stigma or stigmata of insulin resistance, and this condition is exemplified by inability to ovulate. And with the absence of ovulation, there is no egg to be fertilized by a sperm.
You know, I suppose that in your capacity there must be there are some counseling. How do you deal with patients that are obese and you have to drive home the fact or the importance of them losing weight? How do you handle that?
The topic of weight is actually a very tricky one. There are some people, I think, first of all, the most important thing is to have a woman or a patient acknowledge that there is a problem with her weight. Oftentimes, I find that there are lots of women who are somewhat in denial or not willing to address or deal with the issue of their weight. There are some women who are completely comfortable in their skin, regardless of their weight, and then there are others who, for whatever reason, mask or hide their concerns. We don't have a lot of time in the office and with patient uh, visits to address all of the needs that might come up, including, and so oftentimes weight tends to be pushed to the back burner. it's fascinating to me that sometimes when a woman who is clearly overweight or obese is in the office and I've asked her if her primary provider has discussed with her options about weight reduction, or even just discussed with her the fact that she's overweight, um, many women say no, because there are other things that sometimes take precedence over the issue of the weight. So speaking about weight, sometimes you start out simply by, most women I think are aware that they are overweight.
Mm-hmm.
Most women are aware that they are larger, or they're becoming larger and they're needing bigger and bigger clothes, and it's becoming more and more difficult to walk around, and it's becoming harder to climb the stairs. Women, I think, are aware of this. The issue is how to deal with it and how to deal with it effectively. The first is a conversation about diet, conversation about activity, conversation about exercise. There's no easy fix. I mean, most of us, even those of us who are not obese but who are maybe overweight or who would like to shed a few pounds, find it difficult to do so, even with the best of intentions. So it is a difficult subject, and it takes a lot of work, and I'm not sure that we yet have all the answers.
What do you see as the greatest concern some menopausal patients have about their sexuality?
Um, a lot of women who are menopausal complain of absence or decrease of their sex drive or their libido,
Mm-hmm.
um, and that is oftentimes accompanied by physical limitations or discomfort. For example, vaginal dryness and painful intercourse are sometimes very prevalent or very common complaints of women who are menopausal or perimenopausal. That with so discomfort with actual sexual intercourse, coupled with a lack of desire for sexual intercourse, can become very quickly become a vicious circle. At which point women are either abstaining from sex or finding sex repulsive, which can of course lead to interpersonal problems with their personal relationships with their partners.
You mentioned in your ad questions that he may want to ask. And so I'm going to ask this question. So for some guys, when they realized I was having the show, we're discussing this. Does the lack of desire come from the pain and the discomfort, and this is for menopausal patients, or is it hormonal?
I think it's a combination of both.
Mm-hmm.
I think even in women who are not necessarily experiencing vaginal dryness to the point where they have pain, or it's called, the medical term is dyspareunia. Even for those women who may not be experiencing those symptoms, there is a separate event where women sometimes have no physical desire. They either have a desire disorder, meaning that they feel no desire, or they have an arousal disorder. They're not interested, or they're not, or sometimes just the touch of their partner, which used to be pleasurable, no longer feels that way. Some women develop sort of a revulsion to the idea of being touched. And those are changes that are hormonal based. We don't know exactly the etiology of what exactly about the absence of estrogen and the other hormones that are secreted from the ovaries that cause this phenomenon, but that's separate. Added to that, the lack of lubrication, because estrogen, which is usually produced by the ovaries, which are now becoming senescent and not producing as much estrogen, lack of estrogen then leads to decreased viability or moisturization in the vagina, and that of course causes discomfort. Testosterone, which in women is primarily produced in the ovaries, the level of testosterone, as we know, is responsible for sex drive and sexual satisfaction to some degree. If that's lowered, and in women who are menopausal, testosterone levels are very low, that also adds to the decreased libido or sex drive. So it's a combination of both. I don't think it's not necessarily one or the other. I think a lack of desire coupled with pain, okay, makes it not a very interesting proposition. There may be other things a woman might feel that she wants to do instead of be not turned on, as well as feel pain. So
There are some doctors who specialize in raising awareness for and treating chronic pelvic and sexual pain. What might be some causes of these issues, and is this preventable?
Are you speaking about menopausal women or just
No,
women in
just
general? In
general.
general. So the question is, there are doctors who specialize in treating chronic pelvic pain. Okay. So there are many sources or reasons that a woman might have pelvic pain. We call chronic pelvic pain or pelvic pain chronic if a woman has been experiencing it for 6 months or more. Um, and some of the reasons why women experience chronic pelvic pain might be because of gynecological conditions such as fibroids. Fibroids are tumors of the uterus that are not cancerous, mostly in the muscle, from the muscle of the uterus, cells that grow and become sometimes quite large, may cause pain with physical activity, with sex, with the onset of their period, during their period. Some women may have a condition known as endometriosis, which is another medical condition where the cells that are usually found within the lining of the uterus can be found elsewhere outside in the pelvis and other parts of the body, sometimes even as far away as in the lung. But most commonly, the most common place that endometriosis is found would be in the ovary and the surrounding areas. There are theories about how the cells from inside the uterus get there. But putting the theories aside, what in fact it does, this condition, is because the lining cells of the uterus are under the influence of the hormones of the menstrual cycle, cells, even though they're not within the lining of the uterus and are outside, still are under the influence of the local hormones. And so they react in the same way as the cells in the lining of the uterus would, meaning that they are stimulated, they grow, and then with changes in the menstrual cycle, as you would with your period, they bleed with withdrawal. So some women have a lot of bleeding inside their abdomen, which then leads to scarring, which then leads to organs becoming stuck to each other. So women who have, for example, endometriosis that is severe can have chronic pelvic pain because movement is difficult, sex is difficult, defecation is difficult. There can be implants of the endometriosis on the rectum, on the intestine. So that would be another reason for pelvic pain. And then there are other reasons. Women who've had, for example, have had surgery for any reason, cesarean sections or prior pelvic surgery, an ovarian cyst, myomectomy, which is a surgical procedure to remove fibroids. Any of those things can cause residual scarring and inflammation that leads to scarring that then can cause residual pain way into the future.
Are there some treatment for chronic pelvic pain?
There are. There are some treatments. It would depend on what is felt to be the etiology or the reason for the pain. So in the case of endometriosis, for example, there are treatments that are offered. Sometimes oral contraceptives might be used. There are some other hormonal manipulation that can be done. Sometimes surgery is offered in those cases to try to decrease the adhesions, burn away the endometriosis implants. In the case of fibroids, they can be treated usually surgically to remove the large ones that are causing most of the bulk symptoms. Sometimes hysterectomy, which is the complete removal of the uterus, is required. In the case of adhesions from previous pelvic surgeries, for example, there may be a role in lysing or going in to release those adhesions, except that every time we operate, we set in motion the process of inflammation, which is usually protective to make a scar to heal, and those in turn can become cyclical and causing continuation of the problem. I was going to say other women have pelvic pain because of previous infection in the pelvis, for example. Women who've been infected with, say, gonorrhea or chlamydia, as sexually transmitted diseases, can also experience chronic pelvic pain from scarring from those infections, from pelvic inflammatory disease, which is sometimes a consequence of an infection in the pelvis.
In your opinion, why is there such a shameful stigma about sexual pain? And there is this perception that women generally are hesitant to seek help for it. Have you found that to be the case in your role as a gynecologist?
I'd like you to rephrase that, your statement about shame about sexual
Right.
pain.
In your opinion, why is there seem to be this shameful stigma about sexual pain? And then the second part of it is, do you find, because there seems to be a perception that women are embarrassed to seek help or to talk about having sexual pain?
I haven't really encountered I haven't really encountered women who seem to not want to speak about it. It is it is true that all the women who I've had to discuss sexual pain or discomfort with sex with have brought it up. They've been concerned. I wouldn't say that routinely as part of my questions about their menstrual cycle and about their sexual activity that I routinely ask them if sex is painful. I would assume that they would bring it up, but maybe that is a misperception or a misconception on my part.
I'm tempted to ask you how can suffering from this condition affect a person's relationships, but you spoke about that before. You know, let's talk about fertility a bit. It seems that at some point, women do everything they can to avoid pregnancy. And then at another point when it's right, they do everything they can to become pregnant. What are your thoughts on women's fertility?
It's not true that women sometimes do everything they can to not be pregnant. We have a lot of unintended pregnancies that happen every day. I think women sometimes don't necessarily do enough for lots of reasons, of course. Not blaming a woman necessarily, but there are lots of unintended pregnancies. In fact, most pregnancies are a result of unintended pregnancy, meaning that they weren't planned. Not that they aren't desired or wanted, but they weren't planned. And there are lots of reasons for that. There are the limitations of the options or availability that we have to effective birth control measures or methods, and then there are the choices. So I guess more or less the same holds true. Both the availability and the affordability, and then the actual choices that they have, the options that they need to choose among. With regard to fertility, we know that fertility intrinsically wanes as women become older. More and more women in the 21st century are delaying or putting off their fertility or their childbearing, I should say, and choosing to forge ahead with a career, for example, or to make themselves more established prior to starting a family. And that's great. Women have a right, just as men do, to have a career and reach heights that they want to soar to. And if children may inhibit or slow that process down, it's understandable that they may choose to defer their childbearing to later years. But what women must also remember is that their fertility starts to wane somewhere starting around age 32. Recent data suggests that women's fertility wanes from about age 32, increasing or decreasing slowly, but gradually, but effectively over the course of the years to 37, after which it becomes more obvious, and by age 40, significantly more so. So that while women, there are lots of stories about women who have become pregnant over the age of 40, usually with the help of assisted reproductive technologies. That's possible in lots of cases. But in general, I guess women need to keep at the back of their minds that their fertility may be at risk, or their ability to become pregnant, depending on how far into the future they plan to become pregnant.
Any thoughts on the idea that there's a link between oral contraceptive and reduced fertility rate?
No.
Okay.
No thoughts on the matter, because I don't believe it to be true.
What are your thoughts on oral contraceptives for women, and what would you say are the main health benefits and health disadvantages to women using them?
So I'll start with the advantages. So oral contraceptive pills, especially the combination oral contraceptive pills. There are two types of oral contraceptive pills. There are oral contraceptive pills that contain estrogen, and then there are those that don't. So the one that most people refer to as the pill, in quotations, will be the estrogen-containing oral contraceptive pill. Contains a combination of estrogen and a progesterone. Estrogen is usually produced by the ovaries, and progesterone also by the ovaries at different times in the menstrual cycle. the purpose of the menstrual cycle, I think it begins with an understanding of the menstrual cycle and the purpose of the menstrual cycle. And it's fair to say that some women don't necessarily have a good grasp on what the menstrual cycle is and how it works and its very purpose. So most people just see it as a bit of a drag to have a period. So the idea of the menstrual cycle is to prepare your uterus and your ovaries to become pregnant, to be fertilized. So the process usually starts, we consider that the process starts at on the first day, say, of the menstrual cycle, of your period. So the menstrual cycle is the first day of your period, and the menstrual cycle ends on the first day of your next period. And the processes that occur in the ovary and the uterus during that usually about 28-day period is what we call the menstrual cycle. And the oral contraceptive pills, estrogen and progesterone containing pills, sort of mimic to some degree the levels of hormones that would naturally be produced by the ovary. But it mimics it in a way that the ovary, the natural feedback that the ovary receives from the brain and from the hormone levels that are being produced by the ovary are dampened, and so the ovary itself doesn't ovulate. So the hormones in the pill prepare the lining of the uterus to grow. The progesterone changes it to mimic what it would look like if the ovary had produced the hormones. And then when a woman stops the pill, as she does usually every month at the end of her packet, the withdrawal of that progesterone prompts bleeding. And so it's a fake period. It's not a real period, but it serves a purpose. Now, in addition to proving usually the woman is not pregnant, the bleeding is not absolutely necessary. There are some women who opt not to bleed and therefore will keep taking their pills without pause for a longer period of time. But getting back to some of the benefits, we know that the estrogen and the progesterone in the pill can decrease the amount of bleeding at the time of menses or at the time of bleeding. They can protect the ovaries from ovulation. They stop ovulation, so in that way they protect the ovaries from ovarian cancer. So one of the theories about ovarian cancer and how it occurs is that the constant stimulation on a monthly basis, every cycle, of the hormonal fluxes, ups and downs of the hormonal cycles that are associated with menstruation and ovulation, can cause genetic changes or changes in the genetic makeup of the cells in the ovary, and that is what potentially can cause errors that then go on to become cancer. So with inhibition or stopping of ovulation, which is what the oral contraceptive pills do, you protect the ovaries from these perpetual stimulations and therefore protects against ovarian cancer. So we know that oral contraceptive pills are protective against ovarian cancer. Also protective against acne for most women. The hormones that are in the pill bind the testosterone, which is responsible most of the time for causing breakouts. So women get an added benefit usually. So those are some of the advantages. Some of the disadvantages are that for some women, in the beginning, especially of taking the pill, there could be irregular bleeding or spotting that we can see happening for about 3 to 6 months after starting the pill. Some women have nausea, vomiting, breast tenderness. Those are all hormonal changes. Some women actually experience a decrease in sex drive or decrease in libido. Some other women experience an increase in appetite and are prone to weight gain in some cases, depending on the hormone that is chosen in the pill that they're taking. More serious complications would include the possibility of formation of blood clots. So estrogen is associated with the formation of blood clots in some populations. So blood clots that can travel to the lungs, the heart, the head. Rarely, but more commonly, if it would happen, would more commonly be found in women who smoke, because their vasculature is already damaged from smoking, and who are over the age of 35. So the risk is increased in those women, but possible in any woman who takes a combination contraceptive pill.
We're back with Dr. Griffith. Sharon, how does stress affect fertility?
Well, stress affects our homeostasis, meaning our balance, our hormonal or humoral responses, which are our hormonal responses. Stress can disrupt our sleep. It can disrupt the rhythms we call circadian rhythms, which are sleep, the way we are affected by, or how we respond to stressful situations are all mediated by our ability to cope and deal with stress, both physical and emotional. So one of the things that can be affected by stress is our ability to ovulate. So ovulation, we know in some women, and that has happened, I'm sure people can identify that in a stressful situation or having undergone some amount of either physical stress or emotional stress, that they may have skipped a period. And the very skipping of the period would be because of a lack of ovulation in that menstrual cycle. And if that happened on a regular enough basis, it can have an impact on your ability to become pregnant. Because if you don't ovulate, then there's no chance of a sperm and an egg meeting and fertilization occurring.
In the chat room, Jukes asked, why the increased incidence of fibroids in women of African descent?
We don't know exactly why. There seems to be some genetic predisposition. I'm not sure that anyone has isolated a specific gene, but it is true and it is observed that women of color are more likely to have fibroids when compared to their white or Caucasian counterparts. But fibroids are common across all spectra, all races and ethnic groups. It's just that it tends to be found more commonly in women of African descent.
About men, what are some questions you believe men should ask, but probably aren't even aware that they should ask?
I think men, if they're not aware because they've never been taught or instructed, should have a basic understanding of the menstrual cycle and its purpose. Because pregnancy is usually the result of male and female interaction, and men are as responsible for pregnancy as women are. So men need to be able to, I think, the same as women in terms of planning or avoiding unintended pregnancies, if that's our objective here, would be to have a working knowledge of how babies are made, and not make it necessarily only the woman's responsibility to avoid pregnancy if that is the objective.
What would you recommend for perimenopause heavy bleeding?
Well, perimenopausal heavy bleeding is a specific condition, but oftentimes women bleed around time of menopause, and there are reasons why they bleed that are not what we would necessarily classify as perimenopausal menorrhagia. So to be considered to be perimenopausal bleeding or perimenopausal menorrhagia, there needs to be no other explanation for the bleeding that's occurring. So perimenopausal menorrhagia is a diagnosis of exclusion, meaning other things needed to have been excluded. In other words, fibroids or adenomyosis or endometriosis or polyps or endometrial cancer or endometrial hyperplasia. Those are other reasons why women may bleed around the time of menopause that need addressing, that is not perimenopausal menorrhagia or perimenopausal bleeding per se. With perimenopausal bleeding, hormonal treatment usually works well. If there's been no other reason that needs treatment of a different sort, then oral contraceptive pills are usually effective. For some women, there's another drug called Listeda, which manipulates clot formation, and that's on the market now for about, I think, 2 years or maybe more. And that's been shown to be effective for those women who are probably going to enter menopause at any time. We can never really predict when someone will enter menopause, but if a person were to gas somewhere in the next year or so, it can be sort of a stop measure for women so that they wouldn't necessarily need to have surgery or anything more aggressive done.
In the chat room, Cheryl B said, "Good evening. I was late tuning in to the program, and I'm not sure if osteoporosis was discussed. If not, can Dr. Griffith give some insight on this?"
So osteoporosis is a condition where calcium and minerals, phosphorus and others, but mostly calcium, is leached from the bone. Bones are made and kept strong and healthy by the cells of the bones called osteoclasts and osteoblasts. Bone is often always being remodeled, meaning bone is broken down and bone is rebuilt. Osteoclasts break bones down and osteoblasts build bones up. Osteoclasts and osteoblasts are under the influence of estrogen. As estrogen starts to wane, as the levels start to decrease in later years, in menopause or in perimenopause, there's an increased chance of osteopenia, which is a term that we use to describe demineralization of the bone that doesn't meet the criteria set by the World Health Organization or the radiologist to determine osteoporosis, which meets certain landmarks or certain criteria in order to be given that diagnosis. So we call anything between normal and the criteria for osteoporosis, we call that osteopenia. It's usually a warning sign that women should do something to beef up their bone health. Osteoporosis can be a very debilitating condition because it's associated with bone fracture. It used to be felt that women, and it is true, that women of color tend to have less osteoporosis than women who are Caucasian, but women of color also have osteoporosis and cannot take for granted the need to take steps to avoid osteoporosis. So the things that you would do to try to avoid osteoporosis is to encourage a diet that is healthy in calcium and vitamin D, which are required for bone health. Weight-bearing exercises have been shown to help strengthen bone. Weight-bearing exercises stimulate the muscles, for example, weightlifting or climbing the stairs or isometric exercises. Stimulate the muscles attached to the bone, and those stimulate the osteoblasts and osteoclasts and help reformation, so those things are helpful. There are some cases where women need to take extra calcium because they're not getting enough in their diet. And in some cases, women need to take other drugs, pharmaceutical agents, to actually help to replace or to shore up the bone that they may have already lost. The thing about avoiding, the reason why osteoporosis becomes important is because it's associated with fractures, especially of the lower extremities and the hips, and of course collapse of the spinal column. And that's why you may see some women who are humped over. They have what it used to be known as a dowager hump. Their cervical column or cervical spine is sort of collapsed, and so they have that rounded older woman's neck. You see some older women partly doubled over because their vertebral column has basically collapsed from osteoporosis. And fractures lay women up in bed. Fractures and women laid up in bed lead to the formation of blood clots from immobility, and it can be a downhill spiral towards morbidity or even death. So it's important that women avoid osteoporosis if they can.
Can a rigid or a particular exercise program help with waning libido in women?
Not that I'm aware of. We know that exercise increases blood flow to the pelvic organs, and blood flow increase to the pelvic organs is usually a part of the process that goes on when there is sexual arousal. So with sexual arousal and the onset of sexual activity, there's increased blood flow to the pelvic organs, engorgement of the pelvic organs, of the labia, same with the men, for the penis. So we know that blood flow can help, and exercise does increase blood flow. So it is thought that those reasons, blood flow, exercise also makes you feel good. It releases serotonin, which makes you an opioid, which makes you feel better. And so that's the rationale behind recommending exercise. But there is not any specific exercise regimen that I'm aware of that by itself will promote or improve libido. There are some exercises that women can do for vaginal toning. As women get older, there tend to be laxity in the musculature of the pelvis. And there are some exercises famously known as Kegel exercises, which are basically exercises where women contract their pelvic muscles around an imaginary object, perhaps, such as imagining that there's either a penis, a sex toy, a ball, or just the idea that they're imagining that they're stopping the flow of urine. Those are the muscles that are engaged for Kegel exercises. Women are encouraged to do those several times a day. Not stopping the flow of urine, because that can also cause issues with the bladder, but imagining that they're stopping the flow of urine. Practice those exercises to bone up or strengthen their health of the vaginal musculature.
What are some questions you believe women need to ask, but especially young women, that they're not asking? Gynecological questions.
I'm not sure that I can think of questions that they need to ask. Well, I think there are things they need to know. I think they need to be aware that even though there are antibiotic cures for gonorrhea and chlamydia and trichomonas, that they could still be consequences or sequelae of those infections that are far-reaching beyond the immediate infection that they acquire. And I strongly encourage women that unless they are planning to be pregnant, that they should use condoms at all times. They also should be aware that most males who are infected with an STD don't have a sign written somewhere or that shows or says that I have this infection. Most men who have an infection don't have a drip or a leak from their penis or a visible problem. So most women assume that because everything looks okay, it means everything is okay, and that's hardly the truth. And I believe that young women have a responsibility to themselves, even if their partners may not have a responsibility to themselves or to their female partners. The women have a responsibility to always look out for their best interests, and their best interest would be to make certain that their sexual health remains secure.
Why and when are estrogen or estrogen patches necessary?
Estrogen patches are necessary mostly in women who are, well, I don't want to use the word necessary because it implies that they must be given. But estrogen patches are used most often in women who are menopausal or perimenopausal. And they're used to treat the symptoms of menopause or perimenopause, which are called vasomotor symptoms and refer to hot flashes, night sweats. Those are the two most common symptoms that reflect a loss of estrogen. So estrogen deficiency or estrogen withdrawal are characterized by several women. Some women have different complaints. A common theme or thread for most women who are having perimenopausal symptoms are hot flashes and night sweats. Some women also complain of vaginal dryness, others complain of insomnia, others complain of depression, or as we mentioned before, decreased libido. Estrogen is used to replace the estrogen that is no longer being produced in ample quantity from the ovaries, and its sole purpose these days is to treat those symptoms.
What tests and screenings do a woman need each year? And how often should she get a pap smear?
Okay. So there are guidelines that are age based or age appropriate. So if we start with the adolescent woman, so the American College of OB-GYN suggests that an adolescent female or a young woman have her first gynecologic encounter somewhere around age 15 or 16. It isn't necessarily to have a gynecologic exam in the sense of the word as you may imagine it. It doesn't necessarily mean that it must involve a pelvic exam, especially in an adolescent who is virginal. However, it would be to make contact with, to discuss sexual health, discuss changes in adolescent gynecologic changes, puberty, the sequelae of puberty, for example. Women starting at age 21 should have a gynecologic examination, including a pap test. It's recommended every 3 years until age 30. In addition to which, screening for sexually transmitted diseases, gonorrhea, chlamydia, trichomonas, syphilis, hepatitis, and hepatitis B and hepatitis C are sometimes implicated as sexually transmitted. So most practitioners will screen for those as well under the gamut of sexually transmitted organisms. And addressing other emotional health, the other things that are addressed usually at those visits are social history in terms of exposure to domestic violence, exposure to cigarette smoking, illegal or forbidden substances. In women who are between the ages of 30 and 65, the current recommendations are for those women who have no history of cervical dysplasia, dysplasia being the word that defines pre-cancer changes to the cervix. For those women, they can have pap tests done every 5 years with co-testing. That's important to know. Co-testing means testing for human papillomavirus in addition to the pap test. That can be done every 5 years. Those women also would be eligible for mammograms, breast exams, and mammogram screenings, which it's recommended should begin at age 40 and continue indefinitely in the case of women older than 40. Other testing for women in those annual exams or those exams would be screening for sexually transmitted organisms as well, gonorrhea, chlamydia, trichomonas, as I mentioned before, HIV. The CDC guidelines suggest that those women can stop having screening for STDs around age 25, I believe it is, if I'm not mistaken, depending on their risk factors. So, in women where there's in an area where there's a high incidence of sexually transmitted infections, most practitioners will continue to screen women who, for any reason, seem to be at risk for an STD, not in a monogamous relationship, not using condoms, and many different reasons why we may choose to screen them. But the guidelines suggest that in some communities, STD screening may not be necessary after a certain age. And then in women who are older than 65, pap smear screening is usually at the discretion of the provider. Usually the criteria are, usually it is because they have a history of some sort of cervical abnormality for which they need to continue to be screened. There's a separate population who should have pap smears every year, and those will be people who are HIV infected, people who have a history of exposure to DES, which is a estrogen type substance that was used a long time ago to prevent miscarriage. And those women are daughters of the women who took those, are at increased risk of cervical cancer, and so there are some populations who need screening every year. So that brings me to the discussion about human papillomavirus, because I mentioned co-testing. So the pap test a long time ago, approximately I'd say 15 years, 20 years ago, was done primarily every year because all we had was the pap test. Pap test means named after a physician pathologist called Dr. Papanikolaou. So the full word is Papanikolaou, and is actually a method of looking at cells from the cervix the way you would in biology class by scraping the inside of your gum and collecting in your cheek and collecting cells to look under the microscope. Similarly, to look at any changes in cells of the cervix. That's basically what it is. It collects samples of cells from different depths, the most superficial down to a few layers deep in the cervical mucosa. The pathologists look at those and determine if there are any changes, and then they grade them based on a system. In the United States, we use a system called the Bethesda system, where we grade the pap smear as being negative, meaning no sign of any malignancy, and then there's a level where it's atypical or abnormal cells of uncertain significance, and then there's level 1 of what appears to be dysplasia or changes in the cervical cells, level 2, and then level 3, and then malignancy or cancer. But the Pap test is a screening test, and it's not been very reliable because oftentimes it's overcalled or overread because it's pathologists, humans are reading these tests, although these days they are done in association with a computer-generated program. So then came along the advent of the discovery of the role for human papillomavirus. So human papillomavirus, or HPV as it's known in some circles, is a ubiquitous, meaning found in many different places in nature. But in the case of the for gynecologic purposes, we were interested in specific strains of HPV. So HPV is responsible for causing warts that you get on your hands, for example, that you get on your feet, plantar warts, warts on your fingers. They're all different strains of HPV, but there are certain strains that have a predilection for infecting human genitalia. And those would be the ones that cause genital warts. Genital warts, some people may already know, look like cauliflower or broccoli, are highly contagious, passed on from sexual contact, is a sexually transmitted disease. And then they tend to be certain strains of the HPV that cause those types of infections. Whereas the kinds that we are concerned about with regard to Pap tests are the ones that infect the cervix. And in case of men receiving, gay men who receive anal sex, or anal receiving gay men, they may also have infections of their anus with HPV. So HPV infects the cervix or the anus and can in some cases lead to changes that cause cervical squamous cell changes, which we associate with cervical cancer. So we test for HPV now in women who are older than 30 because we know that that is actually the instigator. So there are other reasons why someone with HPV may go on to have cervical cancer and why some others with HPV do not. So there's not just only one incident. It doesn't have just to be the HPV. There are other contributing factors or cofactors such as smoking, such as the type of HPV, which strain it is. Those things are also thought to be important. But now we can screen women and exclude some women from annual screening if their HPV test is negative, and do their screening again in 5 years, because we know that even if a woman left the office with a negative test today and became infected tomorrow with HPV, it takes a certain amount of time before the HPV makes enough changes that can be detected or even make changes that we think are precancerous. So hence the lengthening of the screening interval to either every 3 years without HPV testing or every 5 with HPV testing for most women.
Jukes said, is there any dietary help for those vasomotor symptoms that menopausal or perimenopausal women get?
So there's been some research into dietary supplementation that may be useful for women who are having vasomotor symptoms of perimenopause or menopause, and the data hasn't really borne out that, and that the studies haven't really shown that any of the assumed dietary recommendations actually do work. Mm-hmm. And I think what some people think of immediately are perhaps soy products, because those are the ones that are most often recommended, and that was because of some observations made in Asian women. I think Japanese women, but I could be wrong about the actual ethnic makeup. But in Asian women, it was observed that they barely ever complained of vasomotor symptoms. And the thought was, well, what is it about their lifestyle or about them that made them different from Caucasian women or black women? And it was thought that it was something about their diet. And Asian women eat a lot of soy. They eat a lot of tofu. They love soy products. And so it was thought, yes, it must be the soy. And it was discovered that in soy products, there are what are known as isoflavones or plant estrogens, so to speak. And the thought was, well, these must be somehow or the other substituting for the missing estrogen that women have. And so a lot of research, and maybe to some degree a little bit of hype, was about the use of soy products. But some women do feel, I believe, report some improvement in their symptoms, while others say that this doesn't work. So studies have not borne out that soy has any great influence over controls in alleviating symptoms. There's some other plant substances such as black cohosh, which is a herb which has been shown in some, I believe, German studies in women who took the extract for about 6 months, that they had improvement in their symptoms. The studies only, I think, if I'm not mistaken, went on for 6 months, and I'm not sure how long lasting the results were. In that cohort or group of women, they did report a significant change in their symptoms using black cohosh, which is marketed in the United States as Remy Feminine, but you can find it in the health food store just under its very name, black cohosh, 20 milligrams 2 times a day. But again, the studies have not borne out that there's really been any benefit. Then there's others such as red clover. Some people believe that that can help. Again, the studies don't bear those out. Then there are other things such as maca, which is a root from Peru, I believe, or the Andes somewhere, where some women believe that, some studies have shown, or some people believe that it can improve libido, replace estrogen, and improve overall general sexual and vasomotor health. Again, we don't really have any great studies that show that any of these products really do make a difference. They do for some women, but that could also be placebo effect if none of it is harmful to any degree as far as we can tell. So it doesn't hurt to try. Some women also have found phytoestrogens or plant estrogens are also present in food products such as lentils. So I encourage patients to eat as many lentils as they can tolerate. Make certain that they're getting some exercise, and if their symptoms are not controllable with those homeopathic measures, then it may be worth discussing with their provider estrogen replacement.
I want to take a quick break, but before when we come back, you think about this on your way on the break. Let me just read a few things in the chat room. Cheryl B said, "Thank you, Dr. Griffith, on your advice re osteoporosis." Leslie asked, "When is douching necessary? And what do you advise women with abnormal pap smear?" You want to take that first question?
Which one? The douching? I'd like to take the douching. There are hardly any circumstances under which a woman should douche. I cannot say that enough. There are very rare instances where it may be determined by your healthcare provider that a douche of a specific solution may be necessary to treat what is presumed or thought to be the condition that you have. So under the advice and management of a healthcare provider who is trained to make the determination that you may require a douche, that should be the only circumstance under which douching is necessary. Douching can be very harmful to the local environment in the vagina, which is made up of multiple billions of microorganisms, bacteria and yeast, who we are hoping live in harmony together to create an environment where there's a significant amount of discharge and lubrication for vaginal health. When a person douches, basically they're mostly washing out or diluting the organisms that are there that are actually keeping the vagina in a healthy ecosystem. There is no reason to douche. Douching makes things worse. Douching is usually the reason women have recurrent infections. So there are multiple different, they're not multiple, there are several different conditions we refer to as vaginitis, which have different etiologies or origins or reasons. Douching fixes none of them. Douching, in fact, can make one worse. If there is a problem, and this is what I tell my patients, if there is a problem that you believe might be cured by washing it away, that is a problem that needs to be addressed with your gynecologist. So if ever there is a smell or an itch that you believe washing away would solve the problem, it will not, and therefore you should see a gynecologist.
Let's take a quick break, and when we return, I want you to take Cheryl B's question. Kind of woman in her early 60s who had a hysterectomy, uterus and cervix only removed, have an abnormal pap test, and what are the causes for this?
Okay.
All right. We are back with the lovely Dr. Sharon Griffith. The question I asked before, well, Cheryl B asked, can a woman in her early 60s who had a hysterectomy, uterus and cervix only removed, have an abnormal pap test, and what are the causes for this?
So I'd like to ask Cheryl B. if this is a specific case, or hypothetically, even if it's not a specific case, it would depend on whether or not this uterus and cervix, the hysterectomy, was performed for reasons that were not related to cervical dysplasia or cervical abnormalities, right? So hysterectomies are done for reasons related to cervical abnormalities, precancer lesions of the cervix, or they're done for other reasons, fibroids, endometriosis, adenomyosis, polyps, hemorrhage, those sorts of things. So the question becomes, a woman after hysterectomy certainly can have an abnormal pap test, and it can be for different reasons. One of the reasons could be vaginal atrophy and lack of estrogen, as I mentioned. Even if a woman has her ovaries behind, she specifically mentioned that only the uterus and cervix were removed, implying that her ovaries were left behind. But in a 66-year-old woman, in this hypothetical situation, her ovaries wouldn't be producing enough estrogen, because at 66, you clearly would be in the menopause. Even if you had a uterus, you would have stopped having your period. And so if your ovaries are not producing estrogen, then the vaginal mucosa, which is dependent on estrogen for its life and its health and its moisture, can become dry and thin, and we can see abnormal changes in the cells on the pap test, simply from atrophy or lack of estrogen. So that would be the simplest reason. There could be inflammation, for example, an infection such as yeast, or which are known as candida, or bacterial vaginosis, which is an imbalance, from lack of hormones or hormonal changes, or douching, or antibiotics. That can also cause inflammation in the vagina that can cause an abnormal pap test. So it would depend to what degree the test was abnormal and what it actually said. If it suggests that there were cells that showed effects of HPV, such as a low-grade or even a high-grade lesion, that could be secondary either to a new infection or one that was there before the hysterectomy was performed. Most women who have a hysterectomy for non-cervical dysplasia reasons, non-abnormal cell reasons, who have no history of dysplasia in the past, don't usually need to continue having pap tests after hysterectomy. So most of the time, women who've had a hysterectomy done for benign, what we call benign reasons, fibroids, endometriosis, something like that, don't usually go on with pap screening. If it has been done because their pap test was abnormal.
Or they just, Cheryl B just made a comment, hysterectomy was done for fibroids.
Okay. So usually if a patient has a hysterectomy for fibroids and has no previous history of abnormal pap test of dysplasia, then pap smear screening can be stopped. That's the general consensus. If for some reason the pap test was done anyway, in spite of those recommendations, and we are left with a vagina that now has been pap tested and shows abnormal cells, depending on the level of abnormality, then the patient may need to have further testing done. If it's thought that it's because of atrophy of the vaginal cells or because of inflammation of the vaginal cells, then just treatment with moisturizers or maybe vaginal estrogen can be useful in correcting the problem. If it's thought that it's because of infection with HPV, which could have been there even before the hysterectomy, or it could be a new infection if there's a new partner, then depending on how severe the pap smear appears, you may need to have what's called colposcopy, because you have to consider that an infection with HPV happens from sexual intercourse, which means that it doesn't only infect cervical cells, but the HPV may also infect surrounding cells of the vagina. So it's possible to have vaginal HPV infection in the absence of a cervix, because you have to imagine that with ejaculation, semen and HPV are sprayed the cervix and the vagina, and so the vagina can also be infected. So depending on the degree of infection or what's found on the pap test, it may be necessary to do a procedure or undergo further testing. Usually it's called colposcopy, which is where we look with a magnifying lens, microscope, with the assistance of some vinegar or maybe some iodine to eliminate the areas in the vagina that might be affected. Vaginal cancer is not as common as cervical cancer. Certainly there is vaginal cancer caused by HPV. Most of the times we find dysplasia, it's usually mild, and most women don't need to have their vaginas removed because of HPV infection.
Leslie asked, is it okay to have sex before my pap smear, and how can it affect results?
It's recommended that it's best practice that you abstain from any vaginal instrumentation or vaginal intercourse or manipulation for about 2 days prior to your test, and that's because any bruising or trauma, which is likely to happen in the case of sexual intercourse, can certainly impact the appearance of the cells and may prompt further testing that may ultimately be unnecessary if you had abstained from intercourse prior. So we recommend to not come to the gynecologist. I recommend, I'll take this as a personal request, to not go to the gynecologist having just had intercourse, okay, with semen still present in the vagina, or unless it's for an infertility evaluation or because your infertility doctor asked you to do so, or to just abstain, because it's just best. It just allows us to do a better evaluation and get better results that don't need to be repeated.
And then said condoms make some women itchy. What is the cause of that? Allergy?
Could be. So latex allergy is quite common. Most condoms that people use are made from latex. There are also polyurethane condoms, which are sometimes used in the case of latex allergy, and there are also lambskin condoms, which, while they protect against pregnancy, may not protect against small organisms such as HIV viruses. So women can be itchy for a couple of reasons. Could be the actual material the condom is made from, or it could be the spermicide that the condom is lubricated with, or if not a spermicide, just a lubricant. Some condoms are lubricated with a spermicide, some are just lubricated with a non-spermicidal containing lubricant. And so a woman can be allergic or sensitive to any of those components. It's important though that if a woman is itchy after using a condom, that she be tested to see whether or not she has an allergy to latex, because an allergy to latex can be a very serious condition, can be life-threatening. If you're exposed continuously to an offending allergen, eventually your system may respond in a way that can be life-threatening. So I advise women to, if there's any question about itchiness or irritation with the use of condoms, be tested for latex allergy and eliminate the spermicide or eliminate the lubricant to see if it makes a difference.